So let's talk about traumatic aortic injury. The objectives of this talk are going to be to define traumatic aortic injury and review its etiologies, to describe the radiographic and CT features of traumatic aortic injury. I'm going to talk about both blunt and penetrating aortic injury. What is this entity? As you can see here, this entity has been referred to by many different names: aortic traumatic aortic injury, blunt traumatic aortic injury, and it goes on and on. All of these I'm going to refer to as traumatic aortic injury. And what it is a disruption or partial tear of the aortic wall. This is my sketch of what an artery should look like. There's a lumen, an intima, a media, and an adventitia, and Dr. Kligerman showed us some very nice examples of these earlier today. In preparing this talk, I was trying to look for some cool car crashes and motorcycle injuries, because this is what I see at our ER at Rhode Island Hospital, which is the third busiest in the country. And if you visit these websites, you can probably get a lot of business and perhaps increase the diagnostic yield in these patients. So usually motor vehicle crashes and motorcycle crashes are what we're talking about here. Unfortunately, the patients who make it to the hospital don't have any specific signs or symptoms. Chest pain and dyspnea are most common. This is the real problem. This injury has a horrible prognosis. Up to 90% of the patients who suffer from traumatic aortic injury die before receiving medical attention. And of those small percentage of patients that do make it to the hospital, if they are untreated within the first 24 hours, half of them will die. Traumatic aortic injury is the cause of death in 20% of high-speed motor vehicle crashes. What's the mechanism? There's a few theories. I have 3 stars here pointing to the most common locations of traumatic aortic injury, and a lot of people believe that this injury is due to rapid deceleration due to shearing forces. So when you're reviewing these studies in these patients, please focus on the aortic root, the ligamentum arteriosum at the level of the isthmus, and also at the level of the diaphragm where the aortic is somewhat tethered. Other articles have reported a mechanism referred to as osseous pinch. And if you look at this curved reformat candy cane view of the aorta, you do see a disruption at the level of the isthmus, but also notice there's a fracture, and some people believe that this is compression or pinch between the anterior osseous structures and the posterior osseous structures that result in traumatic aortic injury. The third etiology that I found in the literature is this thing called a water hammer effect. And what that is a rapid increase in pressure during compression when the chest wall goes against the steering wheel. And this is another sagittal reformatted image, again showing an intimal tear and a disruption of the aorta at the level of the isthmus, which is the most common location. This is a surface volume rendered image, again showing a very similar location of an aortic disruption. When I look at all the cases and review the literature, I don't think there's really one key etiology of traumatic aortic injury, but most cases are likely multifactorial, including some degree of shearing, stretching, twisting, and hydrostatic pressure. I'm going to review in the next few slides the typical imaging features of traumatic aortic injury on chest radiograph and on chest CT. And we're going to conclude with several examples. These are the classic findings described on the AP supine chest radiograph. What you're really looking for is widening of the superior mediastinum. Some reports greater than 8 centimeters or greater than 25% of the transthoracic diameter as very sensitive indicators. However, we know our population is getting bigger, and these AP supine views, absolute measurements are often very difficult to make. Look at the aortic arch very carefully. Look for an abnormal contour. Really focus on the AP window, and I'll show you cases of all of these. Left apical capping we've all heard about. And I'd like you to use the central structures as an indicator of shift. Particularly, look at the trachea, which is located midline. Look for that trachea to be shifted to the right. It's very easy to see when there's an endotracheal tube in place or a nasogastric tube in place. Look at the paravertebral and paratracheal stripes. If these are wide, again, this is an injury that you should suspect. The scary thing is, in these patients, I've already told you that very few of them make it to the hospital, and if they're not treated rapidly, this is a very fatal injury. In fact, 7% of patients have a normal chest radiograph. CT is really the imaging modality of choice to make this diagnosis with a 98 to 100% sensitivity. And I don't know if anybody in the audience works in the ER, but I serve my time in the ER when I take call once a month, and I get asked this question basically every time. A clinician will come in and say, I have a patient that just had a trauma. I haven't seen the patient yet, but I would like to exclude aortic dissection, pulmonary embolism, and lung cancer. or some other variety of unrelated diagnoses. What do you do if you don't have a whole list of very specific protocols? Well, I would just ask Dr. Google, and if you Google CT protocols, you'll actually, the first hit is our site, which we maintain with a lot of man hours, person hours, updating these protocols. If you click on that link, you'll get this link, and you can click on chest. And this is a typical protocol that we use in the indication of blunt trauma due to fall, MVA, with concern for thoracic injury. And we have these type of protocols for all available scanners. So I urge you to click on our website if you'd like to see the protocol that we use for the images that I'm about to show. Whatever protocol you decide to use, contrast is really a good thing. What we're really looking for is aortic irregularities, periaortic hemorrhage, contrast extravasation, mediastinal hematoma, pseudoaneurysms, and these intimal flaps, which we just saw in the last talk. You really want to look at the aortic isthmus because 90% of the injuries are located here. The ascending aorta to a lesser extent, and really injuries of the distal descending aorta are really rare, only 2%. We're going to hear a lot about treatment, so I'm going to keep this to a minimum. But if you refer to the literature, there is something called isolated intimal injury, which has been reported to resolve on its own. I haven't seen one of these in my practice. At our institution, really the mainstay of treatment is endovascular stent repair with a technical success of up to 100%. I start with this case. This case actually came to me the week following my acceptance of this talk to this conference. I thought it was very timely. This is a young patient, 18-year-old, with an initial psychotic break who was playing tag on Interstate 95 South and unfortunately got tagged by a truck. If you look at the CT image, it really has all the features of aortic injury. The descending aorta is disrupted and there's active extravasation of contrast into the mediastinum. You can see shift of the airways anteriorly. Look at the mass effect on the pulmonary artery and the hemorrhage in the anterior mediastinum. Unfortunately, this patient didn't do so well. I mentioned the second most common location of traumatic aortic injury is the ascending aorta, and this is a case of a 66-year-old female following a car crash. The arrow posteriorly depicts disruption of the aorta, and always look in the mediastinum and the periaortic soft tissues for this high-density material. So this is periaortic hemorrhage. This patient unfortunately developed tamponade clinically and went emergently to the operating room and was treated with this low porosity graft. You can see the sutures here and here, and this patient did very well. How about these AP supine radiographs that we get in the ER? They're often a mess. There's usually a bunch of lines overlying them. You can see all kinds of external pacing, transcutaneous pacer pads. Well, this is a 59-year-old male following a motor vehicle crash. And I think the more you look, the more you see. Look at the ribs, multiple rib fractures. Anytime you see air above the expected location of the diaphragm, you should really be worrying about a diaphragmatic injury, which will require surgical intervention. In this patient, notice the widening of the mediastinum. Notice the AP window. There's really no AP window. And in fact, it looks like that may be a double aortic arch. Look at the left apical capping, and look at the trachea here. It's really shifted to the right. And on CT, again, in the axial image at the level of the isthmus, you can see irregularity of the posterior wall. And on this nice reconstructed image, you can again see the pseudoaneurysm and contrast extravasation. This patient was treated with endovascular stent graft and did very well. This is a 24-year-old male with a head-on motor vehicle crash. And again, look at the superior mediastinum. It's very wide. This measured about 10 centimeters. The aortic arch, again, irregular, and I don't see an AP window. Again, there's some fluid density in the left apex, and that trachea is really shifted over to the right. Again, these are very concerning for traumatic aortic injury. On CT, you can clearly see this intimal flap, and you can see high-density material in the mediastinum. Again, this patient was treated with an endovascular stent and did very well. Now, what I didn't talk about is ECG gating. At our institution, we get asked to do these studies so frequently that the increased dose of the ECG gating made us decide not to do this on a regular basis. However, in a case like this, where there was some high density in the anterior mediastinum, and there was irregularity of the ascending aortic arch, we repeated the study using ECG gating. And unfortunately, that doesn't always provide you with 100% sensitivity and specificity for traumatic aortic injury. I really wasn't willing to clear the ascending aorta of this patient who had increasing mediastinal high density. So this patient went on to angiography, and actually the aortic root was fine. So I think in some cases, angiograms will be required. When we made the decision not to use ECG gating on all these patients, we anticipated to have to rescan about 2 to 5% of the patients. In reality, we've scanned less than 1% over the last 3 years that we've been using this protocol. These next few cases are unfortunate. These are penetrating injuries, and unfortunately, even though I see a lot of patients with gunshot wounds and stab wounds, I think the patients who develop injuries to the aorta don't usually make it to our hospital in time. So the cases that I have are actually iatrogenic trauma. As you can see in this contrast-enhanced CT scan, there's already a chest tube in place. This patient had an empyema. Unfortunately, despite this tube placement, the patient continued to have fever and elevated white blood cell count, and the thoracic surgery team really felt that it was due to this collection, which was loculated posteriorly. I'm talking about aortic trauma. As you can imagine, the aorta is very close to this collection. Again, these cases are not mine. Someone was asked to do an ultrasound-guided chest tube placement on this collection, which was well seen on ultrasound. The tube was placed. However, no pus was returned, and the patient had severe pain. So you can see here that penetrating injury due to iatrogenic causes does happen. And as my chairman says, if you're not having complications, you're not busy enough. You're not doing enough procedures. This is a nice sagittal reconstruction, and this is the image that you really don't want to see after you've put in a chest tube. So what do? Well, don't pull this thing out until you talk to somebody that knows how to fix it. That's the first thing. So what we decided to do on this patient was transferred to the operating room with thoracic surgery and interventional radiology, as well as the person who placed this tube. So there was a big team of people in the operating room. And you can see on this subtraction image, this is the chest tube going through the aorta. And actually, the catheter that went into the aorta, if you brought it down, you could see it hook. So it was definitely intraluminal. So we put in the catheter for which a stent was to be deployed. We first removed this tube, and then a stent was immediately deployed, and the patient actually did very well. The hemoglobin stayed stable. The patient was discharged home the following day. Okay, another iatrogenic injury, often we're asked to do biopsies of vertebral bodies for either osteomyelitis or metastatic disease. This was a biopsy with the Ackerman system. So there was an 18-gauge needle placed into the vertebral body, and through the 18-gauge needle, a 14-gauge needle was placed. However, after advancing the needle to this point, you can notice there's a lot of necrosis here. Well, there was a little bit too much force applied, and the needle advanced into the aorta. This is only a 18-gauge needle, so in the olden days, we used to do translumbar aortograms using a same size needle, so we felt it was safe to remove this without any intervention, and the patient did fine. The good news is radiologists are not the only ones to have problems with aortic injury. This is a 35-year-old patient who had extensive spinal fusion following a major motor vehicle crash, and I bring your attention to this pedicle screw. This is obviously not the best location for the pedicle screw. And on the reconstructed image, it looks like there may be 2 pedicle screws. Here's a nice volume rendered movie showing the extent of this injury. And there are actually 3 pedicle screws into the aorta. Now what do? Not ideal. But again, patient was taken to the operating room. As you can notice, all the pedicle screws and the hardware was removed, and a stent graft was placed. And this patient also did very well, never needed a transfusion, and had a prolonged hospital stay because the back still had to be repaired. This is the last thing I'm going to show. Usually takes a couple seconds before someone chuckles. If we were to image everybody with traumatic aortic injury, this is the typical finding. Actually, we scanned this patient in our department, I'm embarrassed to say. This is what a CT scan looks in a patient that the heart is no longer beating. You can see all the contrast going through the right heart into the liver and actually into the kidneys. So I hope to drive home the point that most of the patients that have these injuries in the field don't make it to the hospital. I hope you think of this injury and realize how important to treat this injury within 24 hours is. Traumatic aortic injury is fatal in the majority of cases. Patients that make it to the hospital need to be diagnosed promptly. I described some very classic findings on chest radiograph and CT, and feel free to use cardiac gating and angiography for problem solving.